Okay, well, I think we can get started. Why don't we just, if when you speak, if you don't mind, quickly introducing yourself, just so we're all here. I know we can all see your names, but just a quick intro would be great when you're giving some input for that first time. And why don't we start with kind of our first question, set of questions around the last report. So if you had a chance to look at it, and to me, we can talk about any of these questions. So, what do you think worked well? Um, what would you like to see expanded or added? Or on the flip side, what would you like eliminated beyond kind of what we've already heard, which, yeah.
Uh, I can start this if you'd like. My name is Ian Strauss. I'm a retired healthcare administrator as well as a behavioral health crisis supervisor uh, and past chair over the last 2 years of the Healthcare Workforce Committee. Uh, the report, I think, it's sort of all, excuse me, this all falls into sort of one big long sentence, but the report provided a lot of information, uh, in some ways almost too shotgun to be focused. The committee involvement was minimal. We received the draft report and then the final report, but very little in the development phase. And so sort of our input there was also minimal. Um, I think that the report provided great information for a wide variety of people, but didn't have a lot of focus. Uh, Sort of like a marketing campaign, it didn't have a target audience. Um, and so, is this the kind of information you're
Yes, no,
looking
this is
for?
great. No, there's no right answer to this question, but I think we could see that in the report too. We from Choose and RHRC, we do a lot of policy reports specific to kind of policymakers and workforce planners, and so we understand where you're coming from in terms of that feedback.
Okay, great, great. Um, Let me see. Again, I think we tried to do too much with the report. I mean, what was it? 41 recommendations with no structure kind of thing. So one thing I'd love to see in this report, while I think we can certainly do the number of recommendations we find, whatever that is, I think we need to structure that into groups and areas or something that would allow people to focus on the areas that they're looking for in the report. Uh, Let me see. We hit 10 different types of provider groups. At this point, the the OHPV has given us a focus in this next year on what they're calling primary care, which is medical, behavioral health, oral health, and social determinants of health or work or whatever we're calling it nowadays.
Yes.
Um, but really that's their priority and going to be what we're looking at utilizing this report for moving forward, at least in the short term. Uh, and so keeping that awareness, I think, is going to be important. Yeah, I will tell you that oral health and behavioral health are not secondary to medical or primary care, or however we're wording it, in our focus. Uh, Really, we had almost a third of our committee were oral health professionals last year. It was a huge group, and we have the president of the Oregon Dental Association is on our committee this year. There are some really, really focused people looking at doing a lot of work in those areas, and that there is a lot of education in this state and educational need in this state that focuses not only on medical primary care, but also oral health and behavioral health. And so those issues are key in our state right now and are going to be key across the board for this report to be successful. Uh, I think I could go on and on and on, but I think I'll stop here. Does
Great.
anybody else have anything?
Thanks, Ian. Anyone else have any thoughts or perspectives? Yes, Eric, on the
Yeah,
last.
I think the start with the positive stuff, like there's a lot of data in which is fantastic, and we certainly use that data, or I use that data that comes out of the report. I agree that I think some of the recommendations, not only was there a lot of them, and I think one of our desires is to, kind of see where is that accountability piece. Like, so we provided it to the legislature, and then what happens with it as our progress moved on, and I think is a thing that we're looking for. The other thing about the primary care piece, oh, I should introduce myself, sorry. Eric Weiser, I'm a family physician at OHSU. I also direct the Oregon AHEC, and as a side note, and the president-elect of the OAFP. So I think the recommendations. I mean, they almost need to be like SMART goals too. They need to be something to that is actually achievable. Is like pay the workforce more, okay? Like with what funding, right? So like something like that leads that accountability piece. And then the other part about like I think that was short on is like, yeah, if we're short on providers, that's great, but then like what are the ingredients that we need to make those providers? So like where are we on UME and GME and those sorts of slots and residencies and med school slots or PA or FNP slots too? Like you just can't be like, oh, recruit more. I think there needs to be a big aspect of a homegrown nature to this, and so it's just not like pay people more, recruit people more. It's and where should residencies be, and how many, and do we have the right number of med school slots, and what would that look like? I think in general, we are really short on residency slots. Like we are much shorter than Washington State, much shorter than the national average. We happen to match well up with our med school slots, like the number of, but that's really short. Like we have one med school and one campus of that med school, public, and then our private is down in Lebanon. And that's not this like that is like not the same as Washington State for sure. You guys have many more, and even though even as a proportion of the population. So I think like some of those pieces there, and then not to mention like GME slots are so heavily based in Portland. We are well over the federal cap, and so a lot of state resources are going already to existing residency slots, and I'm sure Rob's talking about like the issue that happened out in Bend, which is a consequence of that. So I think there too, like if there is a recommendation to like you need more med school, more residency slots, it's like, well then how do you make them with what funding and what advocacy and those sorts of be there too. So I do like the data on it. There are some places in this report that the data is coalesced more than any other place that I've seen, like with SHOE and PCLF and provider incentive funds and those sorts of things, which are great. But I think the recommendations need to be tangible and then also like have some transparency and some follow up to them.
Great. Thank you. Anyone else kind of thoughts on and we can always come back to it if you think of something later, but on the past report, kind of before I move into more of the main theme of this session.
Could I bring up something? My name is
Yes.
Katie Grubiak. I'm a registered dietitian who has co-created a new nonprofit based in Oregon called Eating Disorder Provider Education Network. And so being here is very enlightening in many ways, and thank you so much for having us all today. But my question is, of course, looking at the report, it's about trying to build infrastructure of providers in all these different areas. My question is, how much focus, or will there be focus on strengthening the capacity of these providers. Something like my nonprofit does is actually bring in to primary care eating disorder treatment, and that is actually through training providers, primary care providers, dietitians, therapists that are already existing, that would be able to have knowledge to assess and treat already within the establishments that are there. So I might be going into a whole other territory, but that is where I'm wondering what has already been said and maybe where we will go in the future with this.
Yeah, I mean, I think I don't have, specific answers in terms of kind of how much. I think when I come from a workforce lens and think about workforce research, that's always something we're thinking about in terms of, just having numbers of providers on the ground doesn't necessarily address systemic issues, right? And so I think we're always wanting to think about the systems that they're working within and that's part of the social determinants of work piece, but I also think that's part of the context piece when we're thinking about context for this workforce in general. Ian has some thoughts too.
Yeah. Katie, so the first, thank you for what looks like public comment to us. And I would say this is a real opportunity. This meeting is specific to a report that we have to put out this year, but the questions you're asking are important and would be at our bi-monthly meetings. That's January, March, blah, blah, blah. We have a section for public comment where we take public comment. We give you 2 to 3 minutes to share a thought, an idea, a subject. And I think this would be great information to share as public comment as part of our regular meetings. Not that we can give you an answer in the meeting, but that it opens that conversation up for the group at large. So that would be my.
Thank you so much for that feedback, Ian. That really is helpful. And I'm just so honored to be here. And thank you for helping me to navigate where more fully my perspective and my comment would lie better and maybe just be more appropriate. So thank you.
No worries. No worries. Thank you for joining us.
Megan, go ahead.
I think for Megan Holland, I'm a family doctor on the South Coast and the CMO at Coquille Valley Hospital, Critical Access Hospital on the South Coast. And I think that the previous needs assessment talked briefly about issues that are very complex that are affecting our workforce. It's not just growing the workforce, it's how do we retain the workforce? How do we prevent burnout? How do we keep people from dropping to part-time because they're getting burned out and overwhelmed and working too many hours? How many of our primary care physicians are choosing not to practice traditional primary care and going into direct primary care or concierge medicine because the workload administratively is so complex. So I feel like these words were brought up in the last report, but every single one of these issues, when you talk about burnout, retention, early retirement, people working less than full time, each one of these has very complex reason and complex solutions, and it would be nice if we could dive in a little bit deeper into those topics. Because we can't fix the problem if we bring people into our communities for 2 years and then they get burned out and they leave.
Definitely. Thanks, Megan. Krista, I see your hand up.
Thank you. Krista Lovis, WVP Health Authority. We're the Independent Provider Association in Marion and Polk County, representing primary and specialty care. I really second what Dr. Weiser and Dr. Holland said, is both pieces of those is the accountability. There's the recommendations and that support, but Where's the funding behind that? And in the next report, what were the outcomes of those recommendations? And what were the positive steps forward in supporting the work that was identified that needs to be done? I think that accountability piece would be really important. And then recognizing that resiliency for primary care is a significant issue. They're being asked to do more and more with less and less. As the specialty providers, that constricts a little bit. So things like what Katie was talking about is providing them additional education, but acknowledging that putting a primary care in the space of treating a complex endocrinology issue because you have no endocrinologist is further pushing that burnout. So I think that needs to be an element of this as well, would be my 2 cents. And when we look at what I'd like to see in the next report.
Thanks.
Just one more thing to
Yes,
add.
go ahead.
Hi, everyone. I'm Laura, fourth year student at OHSU, med student. I really like the report. I felt like it was incredibly comprehensive and in-depth. And at the same time, I think that kind of echoing what Dr. Weiser said, having like smart goals, having like concrete recommendations, I think would be really helpful. So that folks can kind of take away, okay, like this is the situation, this is our reality, but like what are some like realistic things that we can do about it, I think would be helpful. And I sit on the like a board of an organization that kind of does small grants in this Portland area and kind of looking what people like use to cite and to back up what they're bringing to the table. I think that like if we can have simple yet concrete recommendations for folks to kind of jump off on, I think that would be really helpful for kind of thinking about like how, okay, like this is a giant problem, but really like how are folks going to tackle it? And like, especially like how are folks going to find the funding for it would be really useful for them.
Great. I think I think it's a good segue kind of into talking a little more specifically about primary care, the theme of this room, and some of these questions have been answered a bit in terms of, but just thinking about what are the most pressing workforce issues, what data sources would you recommend? So I think, we're learning the data in Oregon and doing our own research, but you all are experts too in terms of, additional information that might be helpful for us to look at as we're putting together this report, and or any other materials that you think should be we should make sure to be looking at. So, yes, go ahead.
On the data issue, and this is I don't know if you guys are going to be able to solve this, but I think I should bring this up, is that I think there's a suspicion that the OMB data is really dirty. So there are like places who are trying to get a HPSA score that's high enough, for example, to be eligible for having a National Health Service Corps member, and they're finding physicians in their that are attributed to their area that have never worked there or were briefly there and then gone. And so I think the data is, and if there's any recommendations about what you guys discover on the data piece to that will be also important. I don't know how other states collect workforce data other than through the boards, but if being analytical about how we collect the data, it will be important. And then I think we've mentioned the kind of burnout too that Megan mentioned, or Dr. Holland. I think too, when we break down workforce per capita, like how many providers per capita, we have to like use some caution with that. Not to mention that, not only is there a trend, I think nationwide of lowering FTE to make things sustainable as a trend. But also I see like Oregon's amazing. Of all the places I worked, primary care has such broad scope, which makes it exciting. But if we have broad scope of like being our own endocrinologist and being our own cardiologist and things, like you just can't have the per capita the panel that some other places have that have narrow scope. And so just using like, well, per capita, you guys should be fine. Like, why is that? Like, I think looking at the role of primary care in total in the healthcare system is also important. So we don't go down that per capita primary care rate or impanelment issue. And then it looks like we have more than we have.
Mm-hmm. No, that's important. Yeah. Ian.
Okay. So I think that, and my guess is you're probably already talking with Piper Block, Andy Davis, the folks from the Workforce Data Project. Hi, Andy. Awesome. Uh, because I think that they're going to be more focused on the individual data sets. I mean, there's plenty out there, but I would just be spewing, data, the HRSA workforce data and blah, 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 some of the larger pieces. But so for data, I wholeheartedly recommend our experts to at least for a focal point. I agree with Dr. Weiser when it comes to the data that comes up for National Health Services core data. It's a mess. My last clinic had to go through each individual provider and do the work ourselves to raise our HPSA score because what was provided to us was worthless. But more for me, the things that we've got going in the state, we recently started in the last year or so, pathway grants. So that were part of the, excuse me, were part of the the how-to grant program originally, I think, but that then moved now to how are we getting people further upstream in the healthcare? I think that any way that we can get that information is going to be important, but also that that's a need in our state that we need to address. I believe there are also excuse me, our data for providers comes from licensing recertification. Okay. So we don't get new providers and we don't get, things that are outside of that data set. So I think that our data set, while solid and good data, is not complete. And that has always left a question in my mind as to how do we know what's going on now when we're not looking at at new providers. I think that's a need that we have that's not currently being addressed. Um, Looking at our oral health, again, pathways, we have, dental assistants, dental advanced practice dental hygienists, all these areas that are now coming into the state that allow us to provide more care. And I'm not sure how much we know about what's going on there. Again, that pathway to providing more care over time, because when the legislature is looking at funding, it's those pathway programs that are going to be a part of that. How are we improving the state? When it comes to primary care, again, we know what's going on with doctors and specialists who, MDs, primary care specialists, reasonably well. I'm not going to say it's great, but we know somewhat what's going on. Tell me about medical assistants, certified medical assistants in the state. Tell me about pathways for my LPNs who could potentially move to an RN status. And that, you know, associate to bachelor's nursing program pieces. All of that, again, it's not it we have a need for more doctors, we have a need for more nurse practitioners, we have a need for more providers, but a lot of the leverage we potentially have is in these supportive services roles that we need to know more about. We our needs assessment strikes in a way that, you know, we need to give people leverage to make a difference at that level. And I think that that's going to be important. I'm going to stop there because, again, this is another soapbox of mine and I could go on forever.
No, I appreciate that. I think without, we aren't collecting data for this project, but I think you're right that there's a lot of data out there. We're very familiar with national data sources, and Oregon has a lot of similar specific state workforces. Workforce data is similar to Washington, which we've worked with Washington's data a lot. So we're familiar with kind of the caveats that always exist when you're thinking about licensure data. And it doesn't mean that we can't learn good information from it. There are ways we need to think about it, and definitely working with Andy and Meredith and that team a lot on those pieces. And then also working hard to get more information about those certified professions that we don't have actually as much data necessarily in the state, but there are data sources around that about them. So there are ways we can, collect information. So I appreciate that, and really helpful information. So Virginia, I saw yes.
Yeah, no, thank you. So Virginia, I go by Vern. I'm the director of health sciences at Clackamas Community College. And so I oversee 7 different allied health programs and training workforce programs, right, in healthcare. And so it was interesting, Ian, bringing up the credentialing kind of piece and medical assisting when we think about primary care and the support services, those roles. Credentialing is a little bit of a challenge. And I know that in Washington state, medical assistants, they have to get licensed. In Oregon, they don't. And so there is a difference in the way of the credentialing. And there are 4 different recognized credentials in the state of Oregon for medical assisting, right? And so they all come with different pathways of education, and it's not the same. And so when you have a medical assistant that goes into ambulatory care that is certified with a certain credential, they might have 1 year of training and all this A&P and all this other things. And then you might have a different credential, and it was a very quick 6-month program that was really so the training differences, because there's no standard curriculum for medical assistants, and then they could be trained on the job and in apprenticeship. So the vast difference in training just in that aspect, and then the credentialing piece. So it's a little bit hard to track. It's always been my well, what is, especially if there's no standard training or educational model for that. And then I think about just all these pathways and stackable opportunities for phlebotomy and into medical assisting and then growing kind of what that looks like. And we do see some of the work being done at the community college level to try to provide that. Stackable credentialing, which I think was one of the recommendations from the last report as well. But it's fascinating to me because